1600. I have seniors that at 16:30 they close their computers and stare at me. Don't do that next semester, but in this case, so disorders of the stomach so different terminology. So duodenum is what, if you Google that, what it'll say, but other people use duodenum, tomato, whatever, I don't care about that stuff. Just don't call it the umbilicus, it's the umbilicus. They will clown you in surgery if you do that. Quick little review of that. I will make sure if there's any questions that have any pictures and ask you to look at this. We want to have an idea of any pathophys. We should not be delving back into that. You dealt with anatomy and physiology in the freshman semester. So this is just a review slide to show you how that works. As far as the stomach, just what I want you to pay attention to is that you have, we'll get into gastric and duodenal ulcers, and you see the duodenum is right down there. That is after the stomach. I want you to just pay attention and have an idea of that. Next slide. Gastric pit, that's how the body absorbs all its nutrients. On the outside, it's also hypersecreting what? Acid, stomach acid, specifically hydrogen atoms that break down food. That'll get a little bit more important when we start talking about duodenal versus gastric ulcers and whatnot. So feel free to raise your hand. Also feel free, if I hit my 50 minutes and I'm just lost in the sauce because I'm having such a great time lecturing you guys, please, some of you keep me on time lock. I usually do a pretty good job of that. I watch the timer, but occasionally I do get a little carried away and excited. So, hiatal hernias. So, we talk about hiatal hernias. So what is this? This is typically like a first world problem. You're not going to see a bunch of these in third world countries. This has a lot to do, this is our main problem with what we call GERD, or heartburn. Okay, and that's because they usually have a hiatal hernia. Anybody know the surgical fix for that? A Nissen fundoplication. So, useless knowledge, maybe, I don't know, but they go in and they essentially tighten that down. That's just right over that slipping through that pyloric stricture there. So, right there, herniation through the stomach. Esophageal hiatus. So that usually slides back and forth. That allows that stomach acid to come back up in the esophagus. People usually get that and eat spicy food, and then they go and lay down in bed, and that just comes right up. Okay? So sliding or paraesophageal. So here's your sliding type. So the GE junction, that's usually above the diaphragm, that's going to be your sliding type. So fundus remains below that. That's the most common type, sliding. Does it sound okay back there? Too loud? Not loud enough? We're good. Thumbs up, outstanding. That's ever not loud enough. And then you have your paraesophageal, which are type 2, 3, and 4. So this is a true hernia with a hernia sac that is constant. It doesn't slide back and forth. So dislocation of the gastric fundus, that is literally sitting up next to the esophagus, not where it's supposed to be. Not where it's supposed to be. For you visual folks, right there. You got your sliding. That slides up and forward. It's going to, based on stomach acid, body anatomy, as far as longitudinal anatomy, if you're laying down, it's going to slide up a little bit more, versus you got your paraesophageal, which is a true outpouching of that. I would say hiatal hernias, they can typically treat with GERD. Usually if we are dealing with a paraesophageal hernia, that is probably going to involve that Nissen fundoplication where they're going to go in. Now a lot of people have complications with that. They go in, they typically tie it down, but that can cause a stricture and cause some problems later on. Just be aware surgery is not always the best thing, So most of these, usually asymptomatic, but they complain of GERD symptoms, gastroesophageal reflux disease. Please don't be like, do you have GERD with your patients? That works great for you guys. You all understand that. But realize 9 times out of 10 you're going to have a non-medical person. Having a non-medical person means, I need to explain this, do you have heartburn? After you eat, do you feel burning in your chest? Okay, I want to make sure. Physical exam, usually unremarkable. I'm not going to do anything with that. You can do heart and lungs all day like you do for your OSCEs and psychobilgus. So, usually found incidentally means on accident, or just we found it perhaps, we're trying to figure things out, we do a scope. Upper GI endoscopy. Now endoscopy is a general term for using a camera. So you can go into the throat, look all the way down to the duodenum, you can go into the rectum and go all the way up to the large colon, usually not further past that. If you're getting both those done, I call it the rotisserie. Rotisserie, yeah. Just make sure you're getting this one done first. Makes sense. Some of you are like, wow. I can explain that to you if you can't figure it out. So, GERD management, usually with small, we don't worry about that. We have these larger ones, refractory surgical repair, that's that Easton fundoplication. So, and we get into these gastropathies and gastritis. So, two different types of things. So, gastropathy means we just have damage without inflammation. I think it's very interesting how you can have damage without inflammation. That's usually autoimmune in nature. And then we have gastritis, which is damage with inflammation. Damage with inflammation. I doubt you're going to get a pants question like this. What's the difference between gastropathy and gastritis? But just so we can talk about things in the future and we're using the same terminology, we want to work those pieces out. So I told you gastritis, usually secondary can be infectious or autoimmune etiologies. Gastropathy secondary to, it's usually kind of self-induced. Self-induced, usually not that much inflammation, so people drink alcohol. Who drinks alcohol in here? So yeah, they did. I knew you were anyway. All right. And then NSAIDs. So NSAIDs are great for different types of things, but if people take them chronically, not something we always want to do. What can we use instead of NSAIDs that aren't going to cause that much damage? We're going to get into it later. Everybody familiar? Oh, pharmacology? What? COX-2 inhibitors, Celebrex, things like that. That's why we do need to have an idea of pharmacology. And then physical stress. We have these people that are like stressed out with work, they're drinking lots of coffee, they had way too many kids, they have 5 jobs. Probably smoke too, just saying. Anyway, so we need to do a biopsy on that to figure out exactly what's going on. So the gastropathy, like I said, NSAIDs, alcohol, but we can also have all these other types of things that can cause that. Mechanical ventilation is not good. If we have to intubate somebody, it's not good for them to be intubated. That's like a lot of side effects with those types of things. So prolonged surgeries, trauma, burns. Anytime we have these people that are laid up, essentially think of them in a hospital bed for a long time, they develop what's called stasis. Their body's not moving along like it should. They're not peeing like they're supposed to. They're not pooping like they're supposed to. They're not breathing normally. So anytime that happens, bacteria likes to sneak its way in, we get stasis and we have all these types of problems and develops gastropathy. Portal hypertension, who do we see that with? Well, that ties right back into the alcohol, right? Ties right back into the alcohol. Significant scarring of the liver, portal veins, they develop varices. It's a bad deal. It's a bad deal. So here's our signs and symptoms. Again, asymptomatic, but we want to make sure they're going to come in very general. So anorexia, they don't feel like they're going to eat. They don't feel like because every time they eat, it causes problems. Epigastric pain, bloating, nausea. So typically, great physical exam, awesome. You still want to make sure you do a good heart-lung, still want to make sure you do a good abdominal exam. Your physical exam is very important. Physical exam is very important because you need to document that stuff. And then usually, once we can't figure it out, let's say we try them on medication, but endoscopy is the way to go. So typically, general surgeons do that, or gastroenterologists. You get a chance in phase 2 to do your surgery rotation, figure out what you need, if they're doing scopes, go in there and get a chance to see what that looks like. Go in there and get a chance to see what that looks like. Okay, NSAID therapy, that's what we see with that gastropathy. All these types of things, when we talk about NSAIDs, we're also talking about aspirin. Aspirin is not necessarily a class of NSAID, although it works on these properties. What does aspirin do specifically? It's anti-platelets. Okay, yeah, so we give that to baby aspirin, 81 milligram a day for somebody who's got coronary artery disease or history of thrombosis, whatever. But all these other different medications, it will behoove you to know trade names or generic names when you're talking to those folks, because they'll tell you, hey, I'm on Motrin. You're like, you're on ibuprofen. Then you'll have like an argument with them. Like, it's the same thing. They still want to argue with you. I'm like, okay, cool, whatever you want to call it. I know what it is. Know those types of things. Be familiar with that. So look at those. I usually don't even ask patients like their history of present illness in the emergency departments or in their past medical history. I just look at medications. Oh, you have coronary artery disease. No, I don't. Okay, whatever. I got patients to see. Let's go. I have empathy and sympathy, just saying. And then prostaglandin. So we have these lipids that are derived from that specific type of acid. And look at that, the COX enzymes. So prostaglandins, what do? Important part of inflammatory response. So response to infection and injury, that's what prostaglandins do. Can this cause nausea, vomiting, and abdominal pain at the same time?
Yes.
Absolutely, absolutely. That's typically what happens when we talk about diabetics. When they have DKA, that's usually prostaglandin release. So what does the body do to try and resolve that? They're going to release more bicarb, which bicarb is going to counteract the what?
Acid.
The acid, okay, the hydrogen atoms. That's what bicarb does. And mucus. So the body's trying to resolve and fix itself to increase or reduce the pH. Want to increase the pH, right? Want to make it more basic, less acidotic, because bad things happen when there's acid in there. Clot can't form, infection creeps in. So also helps as vasodilators. So going to increase the blood flow. If you look at that on ultrasound, that is something described as hyperemia, which just means we have increased blood flow. That's a good thing, but it can also indicate that there's something bad that's going on. So typically from the COX-1. So inhibition, if you want to, if you're a visual learner and you want to look at this and take that in, I don't think there's going to be any test questions specifically on this or this, but if you understand things better with a picture, some people do. I put this in the realm of like the Krebs cycle. I put it in the black box, I lock it away, and I never want to see it again. Okay, but if you understand things better with this, and if you can take your sheet of paper and start this test, I would not waste my time. It's like, can I recreate this? Although I've seen people do it. So, what's that gastropathy? What's our chief symptom? Dyspepsia. I've got some more slides that'll go into that a little bit more. That's just kind of a generalized term for that gnawing type of heartburn, epigastric pain. What do we do with that? We're not really sure. Let's try PPI. So, is PPI going to be on your test tomorrow? Proton pump inhibitor?
Yeah.
Probably. Okay. Those are great things, but they take a little bit longer to get on board. What can we use before that? H2 blockers. We don't go with Zantac anymore. Zantac, ranitidine, that has a black box warning. Like talcum powder apparently causes cancer. Crazy. Everything causes cancer. But we go with what? Famotidine. Famotidine is typically your medication of choice. So discontinuation of the NSAID, most effective, and then we can switch to that COX-2 inhibitor, which is basically we only have one choice out there. Everybody's familiar with that, Celebrex. So if the NSAID must be continued, we can go with a couple different medications. Making sure the medication is taken with milk and meals. So we can add that PPI, we can also add Sucralfate. Anybody have the trade name? That's Carafate. And then we have misoprostol. And I'll explain that a little bit more when we get into peptic ulcer disease. So symptoms don't improve, we need to get an upper GI scope. And we're looking, so PPI for 4 weeks. So they come back in, you say follow up with me in 4 weeks. They're not doing any better. Maybe you try this for another 4 weeks. They come back in, not getting any better, especially if they're older. Keep in mind, majority of what you are going to see in the military is going to be 18 to 42-year-old healthy folks. You're not going to see a lot of this. Just keep in mind, if they're not better in 8 weeks and they're younger, you should probably send them to see a scope. See somebody who can do a scope. So, yes, ethanol has a direct toxic effect on gastric mucosa. So, leads to delayed gastric emptying, which is crazy because when people drink a lot of beer, they usually have to go to the bathroom a lot, right? Just sounds crazy, but just understand with the actual GI tract, we're talking about the portion that poops instead of pees. It can potentially slow down, and anytime we deal with things slowing down, stasis, we cause injury, we cause inflammation, we can cause infection. All right. Alcoholic gastropathy, of course, seen with alcoholics. So dyspepsia, some of these people, because they are severe alcoholics, have chronic nausea, vomiting, what we call minor hematemesis. So what's that? Vomiting of blood. We call minor because it's usually not significant. This is usually younger folks. If they're older and hardcore alcoholics, that's going to be from varices. But if they're younger, that's usually, what do you think we would call that? Anybody familiar with the term Mallory-Weiss tear? That's just a little longitudinal tear, not a full-on tear, not like a Boerhaave. So treatment with that, we tell them, hey, quit drinking. And then there's your H2 blocker, so famotidine, and then PPI, usually for 4 weeks. So stress cathopathy, usually critically ill patients. A lot of these people are intubated, they're in the ICU, they don't even know what's going on. They have underlying coagulopathies because they're having end organ damage with their, what would cause coagulopathies? What organ inside the abdomen? Liver. So they have hepatic injury, now we're having coagulopathies. We're having issues with platelets, we're having issues with all these types of things. And then right there, respiratory failure with mechanical ventilation. Why? You can't wake that person up and say, hey, are you having dyspepsia? No, they're in a coma. They're in a medically induced coma and they're ventilated. So make sure these people, they usually put them on prophylactic gastric suppressions. They put them on intravenous PPI. Anybody have any ideas what medication that would be? I'm trying to tee you guys up for tomorrow with pharmacy and get those juices going. So omeprazole, usually our medication of choice with PPI with that. So usually 40 milligrams, 80 milligrams, whatever, IV. That's just what we do. What else do we do if somebody's bedridden as far as prophylaxis besides PPI? Have you seen the compression things they put on their ankles? What does that prevent? DVT, okay? So very important. So want to make sure we're giving that IV, make sure we're treatment if they do have an active bleed. That PPI, why does that PPI work? Because it's going to increase the pH level, make it more basic. The more acidotic it is inside of the GI tract, the more it's going to bleed. Clots cannot form when it's too acidotic. So that's why it's so important that we get these people on this. And you have your portal hypertension, usually your alcoholics. So we do need to look at that. It's usually a group effort with that. We want to make sure that they're getting good blood flow to that. Yeah, where those varices develop, usually the small outpatching where the veins come in, that's why those gastric varices develop so much. We need to get them on beta blockers, keep that blood pressure low so they don't rupture, and then they start vomiting blood. Now we talk about H. pylori. This is our most common thing. This is a first world problem. We don't see H. pylori in third world countries. H. pylori, a combination of us being obese, being more sedentary, eating more processed food, less fibers, a lot of things like that. So it's this multifactorial thing. So it gets us infiltration of lymphocytes and neutrophils. So dyspepsia, again, about a third of those are going to be asymptomatic, meaning I have H. pylori and I don't even know it. Fine, I don't need anything. So common cause of peptic ulcer disease, we'll get into that. So we can do testing on these folks. You should do testing on your folks. So not necessarily right off the way unless they've had an issue with that. And I tell you, I did have a Ranger student when I was a PA at Mount Fraser Ranger School that came in. He syncopies like 3 times in one day. What the heck's going on with this kid? He's like 27 years old. I can't keep him in. Sent him off to an ER. He was severely anemic, required 2 units of blood. Then I find out, oh, he had a peptic ulcer disease. He had a massive peptic ulcer that was just bleeding and bleeding and bleeding. They went in, endoscope, diagnostic and therapeutic, get him put on medications, get him taken care of. We'll get into peptic ulcer disease here in a little bit, but just be aware those people, chronic GERD patients put themselves at risk for this, as well as suspected or confirmed peptic ulcer disease. How can we do that? We can do a fecal antigen test. Fecal antigen test, very specific. We can do a blood or a breath test, and then we can also do a blood test. Now, I will let you figure that out. What I do with most of those people, I just go ahead and order all of them. That way I know which one I'm going to get back quickly. Plus, what happens if I get one of the 3 that's positive in the other 2 arms? I want to have an idea for myself on that. That's just my own little experiment. So just be aware of that. But your MTF in phase 2 may have a specific protocol, but just be aware, going in with an endoscope and doing biopsy, sending that off is going to be more confirmatory. So anti-secretory therapy for 14 days prior to testing, and then confirmation of eradication. We want to do a test of cure. So what I want to do, if I really want to make sure that that's cured, I'm going to order those 3 tests again. I'll be like, 0 for 3. That's outstanding. That's an N of 3. That's better than an N of 1, if you're familiar with research at all. So usually about a month after having follow-up. Here's your standard treatment. It's obviously a PPI. Figure that out. They need to be compliant with that. They need to take that every day, preferably with meals. And then clarithromycin versus amoxicillin. Make sure that you go back and you need to check somebody's allergies. Very important. You do not want to give somebody a medication they have allergies to. It's pretty sweet. In MHS Genesis, right next to the patient's name, it'll have a little nose. That means they have an allergy to medication. Click on that, make sure they're good. You can go with those types of things. Otherwise, you're reaching for what's bismuth subsalicylate. Right? Isn't that crazy? So salicylate, what is that? It's aspirin. So just keep in mind, if you're dealing with somebody, you're having them shove a crap load of Pepto in, they can potentially overdose on salicylate. Aspirin toxicity. So just be aware, pick those medications, 14 days, make sure they're compliant. Tell your patients, finish your antibiotics whether you feel good or not. I want you to take them. Now we have our atrophic gastritis, so metaplastic with that. So typically from a prolonged, delayed, identified H. pylori, so rarely from PPI use, and then unfortunately can be idiopathic in the elderly. What does that mean? We have no clue. We don't know. Unknown cause, idiopathic. And then we have all these other different flavors. Keep in mind that these can be autoimmune. So if we're looking for B12 deficiency, how do we do that? CBC. What are we looking at specifically? Yeah, so we're going to look at the MCV, and we're determining is that above 100 or below 80 is going to give us an idea of that. Okay, we can know that a little bit more. Keep in mind that not everything is just bacterial. There is viral, there is fungal, there is also parasitic stuff out there. Don't worry about that so much in the U.S., but you have somebody recent travel to Mexico, China, South America, whatever, keeping those in mind. So eosinophilic, very rare as far as a gastritis. That is usually not going to be diagnosed by you. You're going to send them off to see a gastroenterologist. That's going to be like their zebra. Their zebra, just where it's out there. And then you have your idiopathic hypertrophic gastropathy. Probably not going to see that on the pants. I would not put a lot of credence in that one. Okay? Questions about gastritis? Major Kelly ever do check on learnings with you guys? Anybody familiar with that? As far as you bring up like a question? All right, well, I'll see what I can do about that. Otherwise, just give you guys a solid review. So we're going to get in, moving along. Plenty of time, halfway through right now. Peptic ulcer, defect in it's either gastric or duodenal, and I showed you that picture. Gastric, stomach, duodenal after that, where it's flowing into where? Small intestine after that, okay. Impaired mucosal defense mechanisms. Why does this happen? Typically too much acid being produced. Highly prevalent disease. Again, first world problems. You're not going to see a lot of these if you are downrange in a third world country. So duodenal ulcers are declining. Where we have gastric ulcers are remaining steady. Typically, the same NSAIDs, we're going to throw aspirin in that mix as well. Anybody have any other idea of medications that can potentially predispose somebody to peptic ulcer disease? So chronic steroids. Somebody said it, yeah. So, I don't care what you probably said about you guys. All right, duodenal ulcers. So we need to know your demographics. When you get into emergency medicine with me, we need to know where we're going to see. So duodenal ulcers, younger folks. Gastric ulcers, older folks. So that could potentially be a pants question. And we alluded to these already. NSAIDs, H. pylori, but we have these hypersecretory conditions. So we'll get into that a little bit later. I'll explain that. But CMV, just realize chronic disease states, Crohn's disease, lymphomas, these people are immunocompromised or immunosuppressed, which allows the opening for any type of opportunistic infection. What is that opportunistic infection typically? H. pylori. H. pylori, but realize it can be any number of things. So I used this term earlier, dyspepsia, but here's a little bit more on that. Gnawing, aching. Now, that's not a mispronunciation. That is not a misspelled word. That is old school medicine, hunger, pangs. You can look it up. I'm like, he doesn't know how to spell. Well, it's not my slide. Major Kelly doesn't know how to spell. Kidding. He's awesome. I've known him for a very long time. So, cyclic in nature. So, typically some type of way that is with your circadian rhythms, where that happens at night more, in the morning. However, So usually 2 to 4 hours after for duodenal. That gastric is going to hit the gastric ulcer first, then do duodenal. So that typically is going to be considered right away. So increased with food or antacid. These typical people are like popping tums like crazy. So, and then nocturnal pain, we need to be a little bit more concerned of duodenal ulcers. Why do we say duodenal ulcers more in nocturnal? That has a little bit more to do, so the food and the antacids help out with that. When there's nothing on there and they're at night and their body's hungry and starting to peristalse, that's when we're going to see these duodenal ulcers. Again, 70% asymptomatic. That's like 7 out of 10 people are asymptomatic. That really helps out with your clinical acumen, right? Crazy. So just be aware, we really worry about these folks with bleeding and perforation. So what is the number one cause of an upper GI bleed? What are we talking about right now? Jesus. Come on, folks. Peptic ulcer disease. What's the number one cause in a chronic alcoholic? Esophageal varices. Okay, that's how that works out. Peptic ulcer disease number one, and let's say everybody, you find out because they have spider angiomas, they reek of alcohol, some other different types of things, pulmonary erythema, a bunch of other very interesting things. So here we see gastric versus duodenal. So increase with pain median. Why? Because as soon as that food hits there, it's going to start secreting acid to break down that food. So decrease in pain, typically increase with hunger. So that's going to be push from like, I just ate, I'm not having so much pain, but then later at night, they report more pain with a duodenal ulcer. So we want to make sure that we ask these questions. So, hey, have you been taking a lot of NSAIDs? Have you been taking, or have you had a history of H. pylori? So, again, maybe some mild epigastric tenderness. You do your exam, otherwise unremarkable. If you have any alarming signs, immediate endoscopy and referral. So there's nothing on the slide, but what would be an alarming sign? Let's say somebody comes in that like vomited blood and now they syncopized. They're hypotense, they're tachycardic. So we have something called the ABC score for a massive transfusion protocol. They are tachycardic over 120 and systolic blood pressure is below 90. That gives you carte blanche to start a massive transfusion protocol. But maybe with these folks, what they really need, you've given blood and you're calling the gastroenterologist or general surgeon to come down. I need you to scope them right now. And maybe that could be diagnostic and therapeutic. What are we getting as far as labs? So let's say for you guys, you're not working in the ER, you're working in your TMC. This person comes in, they've had dyspepsia, you've treated them, all this stuff. Let's go ahead and get that CBC. Fecal occult blood tests, WAC testing. Senior year, you will get your opportunity to get some digital rectal exams. Something you're going to have to do in phase 2. Anybody who wants to go to special forces, that's typically a requirement. Rectal exam over the age of 40, wants to go to Ranger School. I'll tell you that is a defining factor between you and your sergeant major. Give them the sheet, we got to do that. Why do that, sergeant major? And then I say, what do I say? Don't let me catch you smiling, or that's why I get the big bucks. I give it a dealer choice. Just saying. All right, H. pylori testing. We talked about all the different ways that we can do that. So you figure out what your capabilities are to your MTF. I recommend trying to order all 3. And then EGD, esophageal, gastroduodenal scope, definitively establish a diagnosis for peptic ulcer disease. And what does that look like? And I encourage you to look up things on the internet. It's a great tool to use before you start your rotation, because you're going to get pimped by surgeons and whatnot. When I say pimped, they're going to ask you questions. What is that? And they're like, what is that? Oh, that looks like peptic ulcer disease. Good job. And I was like, take over the scope. And you're like, what? No. Sometimes it does happen if they know what they're doing. So just to be aware, you see that ulceration. Those don't look horrible as in not bleeding significantly, but they can be bleeding significantly. And when those perf, that's bad news. Bad news, because now we're dealing with esophageal materials or fecal material where it's not supposed to be. So typically, NSAID, we want to stop that. We want them to reduce it, switch to that COX-2 inhibitor, Celebrex, And then that's just a repeat of an earlier slide with H. pylori with your medications. Again, I'm going to go back over and look over the tests. I had a very short time to burst. We're getting in here. I taught GU last semester to the seniors. They gave me a week before knowing that. But I taught male GU, which is very exciting. 92 slides about the penis, where every other slide is a, you know what? It's outstanding. And then we went on to prostatitis. Now it's 95 slides of every other slide being a, yeah. All right. We talked about PPIs. There are several different PPIs out there. These have gone to where people can buy them over the counter. But the difference between over the counter PPI and prescribed PPI is going to be usually the amount of dosage. We want to give them the healthy dose. So we want to give them a prescription, plus you're in the military. By the way, sidebar, military medicine is not revenue driven whatsoever. So plan on having to fight for your patients. Just saying. It's kind of a sad thing for you National Guard folks. Yes, you have to graduate and find your own job, but you also don't have to deal with a revenue not driven system. Different ballgame. And we talk about our sulfurate right there, Carafate, other medication that coats the stomach to help out with that ulceration. And then misoprostol, Cytotec, prostaglandin analog. So that's going to inhibit gastric acid secretion during the day and at night. And then it's also going to be producing productive mucus as well as what combats hydrogen atoms? Good job. All right. Then we also want to make sure, so we talked about a preventive medicine piece. Hey, I want you eating meals at regular intervals. I want you to avoid those types of things that are going to exacerbate that. Slow down with coffee. Definitely quit smoking. Definitely quit smoking, these folks. So smoking just slows everything down and causes more damage. Why? Because we don't want to develop complications. Right here. Here's our complication. I have a test question: what's the most common complication that we get concerned about with peptic ulcer disease? And that is hemorrhage, gastrointestinal hemorrhage. So low mortality because they typically don't bleed that much, they're ulcerated. So signs and symptoms, symptomasis, you want to quantify that. How much did you vomit? Because if they told me they vomited like handfuls and handfuls of blood, I'm going to put an NG tube down the throat. Okay? And it does go down the throat, but first to the nose. And then melena, that's where stool and blood are mixed together. Any people that have worked in a hospital for a long time, nurses, melena has a very distinct smell to it. You cannot miss it, but you need to take a look back there. We quantify the amount of bleeding. So melena just means it's usually fast transit. It's coming from the upper GI tract to the lower GI tract. Treatment, okay, endoscopy, where they can go in and particularly do hemostasis, because it's very hard to do hemostasis from the outside when we're talking about the esophagus. That needs to be a scope that's doing that, whether they're going to do some type of burning, some type of cautery, whatever. So we do get concerned about this right here. Ulcer perforation, which leads to chemical peritonitis, which means we have material that is now supposed to be in the gastric content is outside of that. Anytime you get something that's supposed to stay in the gastrointestinal tract, it's bad. That's the same thing for lipase. What secretes lipase? Pancreas. If we have pancreatic lipase outside of the pancreas and where it's going through specific ducts and into the GI tract, it eats the body away. It's bad. So we get peritonitis with these folks. They get rigidity, a rigid abdomen, and they can develop something called pneumoperitoneum, which is one of the few times that we will order a upright chest x-ray. Because why? What are we looking for there? Pneumoperitoneum. That means we have a rupture. Air is now where it's not supposed to be, and if air is not where it's supposed to be, gastric contents probably are as well. That is a medical emergency. Laparotomy and looking in, and there's like pretty easy to see what's large intestine, but figuring out small intestine is just it's a hot mess, and you see like surgeons just like picking up stuff, and you're like, I don't know what that is. So here are your three flavors we're going to get into as far as disorders of the small bowel, also known as small intestine. So the malabsorption disorders, we're going to go kind of disorder, motility, and miscellaneous. Here's your order specifically. Some of you are probably a little bit more in tune with these types of things. If you ever hear somebody that says, oh, I have a gluten allergy, there's a lot of people that just like to say they have that, and it's not cool. You really don't have celiac disease, which is true gluten allergy. And we'll get into all these as well. And then just be aware you have malabsorption, which is the body can't absorb nutrients. Maldigestion, which means it can't break down molecules into the nutrients that we need to. And then we have malnutrition, which means the nutrients aren't even in the mix. Okay? First world problems. First world problems. Just for your review here, what I want you to pay attention to is specific types of things, because we're really going to focus in a little bit more on your different types of anemias. So you'll have iron, jejunum, folate, and ileum being more vitamin B12. That's what I want you to take from this. Here's a couple more definitions for you, and these are specifically your malabsorption disorders. So steatorrhea. These people complain of greasy stools. Not everybody looks in the toilet, but if they did, those stools are floating. Those stools are floating. Increased fecal fat. And then we have our microcytic and our macrocytic anemias. So how does that break down? Macrocytic being your B12 and folate. Now, how far do we have to go back? How many semesters? You guys? Some of you haven't dumped it all, I'm glad. Wait till you get to your senior semester, you'll have dumped all your ortho from here. Guaranteed. If you're Army and you don't know ortho, you're going to have a very tough time as a PA. That's like 90% of what you're going to feel like. And then microcytic being iron, and then we have our dietary intolerance. So people with lactate disease or people with our celiac disease. That's adorable. That's all I have to say about that. She's got a scarf and glasses. Pretty sweet. All right, celiac disease. This is our gluten sensitivity. And not everybody that says they have a gluten allergy, do they even know what this means? What I see this with? Northern European descent. These are people that have gluten. So because of that, and that gluten gets in there, it causes diffuse damage, especially the proximal small intestine. Proximal small intestine. So what is that caused by? Wheat, barley, and rye. What do most people figure this out when they're a little bit older? When they turn 21. And they start drinking beer. And they're like, damn it, why does this happen every time? Now, all these awesome terms, I will blame it on Major Kelly for throwing all this stuff in, because I had to look them all up. These are just different terms that describe wheat, barley, or rye. So bulgur is specifically wheat, farro is whole grain and barley. Kamut is a term from Asia to describe wheat. Spelt is wheat specifically from Europe or Spain. Triticale, hybrid of wheat and rye from Scotland and Germany. So glad they put all that in there. So the biggest thing, beer. Yes, there is beer out there that is gluten-free. So that pretty much limits, like, you have 2 choices now. And you go to Perry's and you're like, but they have 50 choices. No, you get 2 now. Sorry. Okay? Most of these people have these issues for several years and they do not know what's happening. You need to have a clinical suspicion. So ask them, hey, when does this happen? Any time that I have anything that's wheat related, that's breads, specifically beer, is probably going to be the number 1 culprit. So again, if it's not in your differential, you're not going to diagnose it. It's not in your differential, unless the CT scan comes back and says gluten out, it's not going to say that. But just then, be aware of those. How do these present? Again, that heartburn, dyspepsia, so diarrhea, and those fatty stools, weight loss. These people complain of a lot of flatulence. And then let me see here. I had to look this one up. Let's see. Ready?
Barbarigmus.
Barbarigmus, which I was like, sweet. That is a great word that I had no clue about. So barbarigme, just a word. If your stomach is making growling noises because you're hungry or whatever. Like, there's a word for that? That's sweet. Be careful, don't use that at a bar. It's a $15 word. Somebody should kick your ass. A rumbling or gurgling sound made from movement of fluid and gas in the intestines. You should be like, oh, Barbarissus, you have celiac. All right, moving along here. Come on. Now we have other types of things, manifestations. Some people are going to complain of tired, depression, iron deficiency, anemia. Women specifically can miss a menstrual cycle. So transaminitis, so we're going to have LFTs, they're going to be elevated, ALT, AST, transaminitis, osteomalacia because of lack of vitamin D, and then dermatitis pediformis, I have a slide for that next. Atrophic glossitis. So that is typically when somebody is going to come in, they are going to have lost all the filiform and fungiform papillae on the surface of the tongue. So it's going to look at smooth, glossy appearance of that. There's the picture for you. But here's the other thing that shows up. Cutaneous manifestation of celiac. These are things to look for. So that's why they have GI complaints, but we also need to look at the skin. That's very important, especially when we're dealing with people potentially that are alcoholics and they're not going to. Here's honestly, how many soldiers are truly honest with how much they drink when they come in and talk to you? Yeah, exactly. Exactly. I'm not saying to bust them out, but I do occasionally have to tell soldiers, come on, Dad, I need to be honest with me. Let's go. So just be aware that these can show up, these herpes-like vesicles, usually the extensor surfaces of the extremities, as well as the trunk, scalp, and the neck. So, I love this. Mild cases, typically unremarkable. Here we go again. Typically unremarkable, which just means you need to be more of a private eye. You need to be a sleuth figuring these things out. So, look for nutrient deficiencies. How are we going to work that up? CBC, CMP, UA. So we're trying to get everything. Those are going to be mostly labs of exclusion to make sure we're not dealing with other things that's going on. I can give you an idea of that. Then we're going to order that IgA. That is the test of choice. IgA levels. So we can order that antibody, but we also want to get the IgA level separate. And then if we really have that positive, then we order this IgG level next to give us much more of an idea. If we get that positive, then obviously they're going to move on to eating a biopsy. But just be aware, this is the most abundant type of antibody, so we need to think IgA with that. So if that antibody's there, it means that it's preventing the body from maintaining immune homeostasis and preventing microbial invasion. So we potentially need to get a biopsy. How's that going to be done? Endoscopy, of course. Endoscopy. And if they get a normal biopsy with that, they can basically say, hey, even though that was slightly elevated, they don't have a celiac. They don't have celiac. So histological examination is just taking that tissue, looking under a microscope, not necessarily with a pathologist, but most likely. And when they look under that, they're going to see that top being normal, bottom being abnormal. So you can see there's a lot of swelling that's caused chronic inflammation, secondary to what the gluten. Just keep in mind, keep your differential, keep your aperture wide. I recommend in phase 2, you casting a wider net when you have people coming in. If it's not on your differential, you're not diagnosed it, but here's other things that can run with. Irritable bowel syndrome, they can just have chronic diarrhea. Tropical sprue, that has to do with people in certain areas of the United States. We'll talk about that one coming up. And then as well as lactose intolerance. And then just a generalized gastroenteritis, which can be bacterial or viral in nature, even could be parasitic or fungal, but less likely. So a diagnostic approach, histopathologic examination just means we look at it under a microscope. Serologic testing is blood, mucosal biopsy, endoscope, taking a sample, and then we trial them on a gluten-free diet, which should resolve their symptoms. We need to remove that gluten from the diet, including oats, because some people can have some cross-sensitivity with that. And usually within 2 to 3 weeks, we're taken care of. We usually prefer these folks to a nutritionist as well, just to make sure that whatever they're missing from that gluten-free diet, they can figure out what other types of foods that they can gain that from. So, usually people are non-compliant, and what does that happen? They like to eat those types of things like screw it, I'm going to deal with that. Similar to people that are lactose intolerant, what are they going to do? I mean, ice cream tastes good, let's be honest. Everybody agrees that. So, and then if the symptoms persist, there's potential that they get sent over to a gastroenterologist. Those are smart guys that can figure out. Gastroenterologist, typically a surgeon that goes and specializes for like another 4 years after they've already done 5 years of surgery residency. 4 more years just to be a gastroenterologist. So they're really hunting zebras then. Questions on celiac? Alrighty. Very appropriate, I guess. Drumming. I get the Costco brand stuff. Just got to buy in bulk. 4 people in my house. Freaking 17-year-olds like, man. You want to do it, 12 years is crazy. All right, Whipple disease. Trophophthirma whipplei. So this is a crazy thing. This is a bacterial infection. It did not get this name until 1991, so this is like a newer type of disease process. We look at our demographic, white males. Does that mean it can be other people? Absolutely, but majority of our demographic, 30 to 50. This is not human-to-human spread, so not given from somebody from like making out or whatever like that. So usually farm or sewage workers, they get in contact with that sewage, wastewater. If we leave this alone, they can die. How does that show up? We start worrying. They're going to have migratory arthralgias. They're going to move around their body, usually major joints. So knees, hips, shoulders, elbows, usually not in the hands and feet. Complain of abdominal pain, usually significant diarrhea with flatulence and those fecal stools that are fatty, and then weight loss. Make sure we're looking at the skin again, hyperpigmentation. They can have lymphadenopathy all over. There's a reason why you look for lymph nodes on each other. I know it seems crazy, but you want to do that. So, ophthalmoplegia. Any idea what that means? So these are people, if you were to try and do extraocular movements, which we do in H, up, down, across, they have paralysis of their eye muscles. Usually affects all the eye muscles. Paralysis of the eye muscles. Sorry, I really thank Major Kelly for putting all these words that I had to relearn. So I'm going to teach you guys. I'm not going to throw that out there and be like, have fun. Nystagmus, typically it's going to be lateral. Okay. Where do we see nystagmus in? Somebody suffering from vertigo. What else do we see nystagmus in besides Whipple disease? So yeah, that's how they get field sobriety tests. And those don't lie. Those don't lie. If it's going up and down, you need to be worried about a central cause, something going on in the brain. Okay, how do we treat that? Ceftriaxone daily for 2 weeks or intramuscular penicillin. So, followed by Bactrim for 12 more months. Holy cow. That's a lot, that's a long. And then, so we see that Whipple disease, we see those arthralgias, we see that malabsorption, diarrhea, lymphadenopathy. They talk about encephalopathy in that little picture there. I will tell you rarely, I'm not going to test you on it, or I'm going to make sure it's not on the test, and if it is, I'll let you know. Endocarditis can also be a complication of this, very rare. And then we talk about a tropical sprue, not to be confused with celiac sprue. This is a tropical sprue. There's your demographic, usually within north and south of the equator, about 30 degrees latitude. So this is a environmental enteropathy. So tropical malabsorption. So chronic disease, typically infectious in nature is what they think. So small intestine, all involved. And how does that typically affect? So folic acid and B12, which is going to be macrocytic or megaloblastic, okay, not micro. And then how we see that with chronic diarrhea, those fatty stools, weight loss, anorexia, and they're right there. B12 and folate, very types of things that you should see as far as physical manifestations, or what we call cutaneous exanthems, which is just a cool word for stuff that shows up in the skin, right there. So we have inflammation of the tongue, glossitis, and then cheilitis. So that typically shows up as little kind of hyperpigmentations in the corners of the mouth. So like I said, megaloblastic anemia. Here's what the endoscopy will show. So flattening of the duodenal folds, and then microscopic findings. We look under a microscope, we're going to see blunted villi, shortened and elongated crypts. So again, megaloblastic, meaning B12 and folate deficient. Prevention, we need to make sure that they're boiling the water, drinking bottled water in those tropical areas. Yes, they can't just dig into a piece of fruit. We recommend they remove the skin. So prevention is going to be very key with this. And then, but that's a long time to be on doxy or tetracycline. Most of you, when you go down range, are on doxy anyway for malaria prevention. Okay? Or you can get put on mefloquine, which is like once a week, which I prefer, but mefloquine can give you dreams. So, interesting fun fact right there. If you guys are trivia folks, I got trivia tonight. Hopefully you're gonna Sally's the nerd out, but we're a drinking team with a trivia problem. Nice. So Where's that? NF arm's really in your brains. I got it. Okay. Lactase deficiency, lactase deficiency. These are people say I can't have what things? Milk, ice cream, cheese, yogurt. Think out of those, I'd be like, oh, I can't have yogurt. What do you do? The other three, I'd be a little upset. So again, it takes it. If you have lactase, you're not lactase deficient. You can take glucose and turn lactose into glucose and galactose. That provides your body. If you don't have that, it's going to get malabsorbed and get fermented, causing bacteria with gas and organic acids. So milk, cheese, ice cream, yogurt, things that all are pretty tasty. So dose dependent, most people say, oh, I can just take a little bit. If I take a moderate amount, it causes bloating, flatulence, and then take a large intake, and they're like, when I say osmotic diarrhea, that's not like, oh, I had diarrhea like 2 times a day. That's not diarrhea. Lactase deficiency diarrhea is like, I have to stay on the toilet. You have to read a lot that way. So usually 1 to 2 hours after ingestion. I love this, typically unremarkable. All these physical exams are just unremarkable. But pay attention, malabsorption can occur, so weight loss. If there is weight loss, we need to potentially think that there's other causes with that. So we don't usually have to do anything laboratory-wise. We just say, hey, stay away from that. Don't eat any milk, cheese, ice cream, yogurt for 2 weeks, and if it goes away, then we're like, okay. But if you really want that confirmatory, you have a patient that's just adamant about it, there is a hydrogen breath test. So there's a hydrogen breath test, but ultimately, we just reduce that lactose and then consider nutrition consultation. There are alternatives to that. You just say, hey, look up lactase deficiency and figure out what you need to go to HEB and get, so that you can get these types of things into your system. Yes, you can have stuff that does not have either lactose in it, or it has lactase in it to supplement your body. Most of these, it is a lactase enzyme replacement that helps out with that. All right, more highbrow stuff. Small intestinal bacterial overgrowth. Yes, that is a syndrome. It is what it says. So bacterial proliferation. So how does this get caused? Usually PPIU, so lack of gastric hydrochloric acid that's going on there. From significant PPI use can cause this to happen. And then we have all these abnormalities. A lot of these are related to surgical complications. And then obviously your motility disorders, and then any type of visualization. How does this present? Right there, obviously we have those types of symptoms they're going to have, but most people aren't going to be able to explain, and you don't say you have steatorrhea. You explain that to them. Do your stools float? They seem like they're really fatty and greasy. Yes, you get to talk about poop with people, pretty exciting. And then look at that macrocytic anemia, obviously going to need a CT. Again, no specific findings, if any, outstanding. 2 different tests for that. So hydrogen and methane, and that can be used based on your MTF, whether that's a glucose test or a lactose test. So treating them with antibiotics that cover down on your aerobic and your anaerobic bacteria. So fluoroquinolones, you have augmentin, also known as mycelium flavonolic acid, and rifaximin. So short bowel syndrome, that's when people get a significant amount of bowel that's removed. That is usually due to some sort of colectomy, whether they had a perforation or they have a cancer or something that had to be removed. So based on the length of that resection, the site of that, we have an idea. We talked about small intestine, where we have the iron, and we have folate, and then we have B12. So you typically will see that relate. Gotta love these slides. It's great. These are great. Questions about malabsorption disorders. Speed still good for you folks? You're like, hell yeah, we want to get going. I got stuff to do. All right. Here's your 3 flavors here. Acute paralytic ileus, your chronic intestinal pseudo-obstruction, and small bowel obstruction. Small bowel obstruction, probably the most common what you'll see with these. But we have our acute paralytic ileus, adynamic ileus. That's just what people have typically a surgery. After a surgery, post-operative ileus, which is why they want them to say, hey, we'll let you leave from your same grade surgery if you can show us that you can urinate and you can defecate. So you can have that without mechanical obstruction. So hospitalized patients, specifically any type of abdominal instrumentation. A lot of this is secondary to all the sedatives and the medications that they give these folks. And then anytime you go and instrumentate inside of the abdomen, it just kind of slows everything down. We worry about our people with severe illness with that as well. These are people that are typically in an ICU dealing with respiratory failure, meaning they're intubated, sepsis, uremia. So these are people in bad shape. And then we always worry about side effects of anticholinergics and opioids. What is an example of an anticholinergic? So anything that is things that take care of allergies. Okay.
TCA.
All right. So we worry about opioids. So anytime you're giving somebody an opioid, I always consider giving them a stool softener as well. So how does loperamide work? Loperamide is basically an opioid without the opioid capabilities of pain control. That's why loperamide works. Take 2 after each loose stool, no more than 8 in a 24-hour period. That's how loperamide works. Anyway, and then trauma. We're about these trauma folks. So diffuse constant abdominal pain because they're not moving anything along. It's not typically with the peristalsis where it's colicky. They can have nausea, vomiting, and then usually distension. That's why we make sure we expose every abdomen. If we're looking at somebody in our hospital, we need to make sure bending the knees, taking a good look at the abdomen, running through your whole processes with that. If I have somebody who I can just tell is a little bit of hypochondriac, and I touch their stomach and they like freak out on me, very simple to pull your stethoscope out and while you're auscultating, push a little bit. And when they respond, you're giving the same pressure you did with your fingers with palpation, and they're perfectly fine. You're like, okay, I got your number. You're going to have those people out there that just feel like they need to see that. You do review systems and answer yes to everything. Guarantee fibromyalgia is in that frickin' on your past medical history too. Not fun. People drain my life. Labs. So CBC, CMP, mostly looking at electrolytes with that peristalsis. What do we need to replete? So if they are potentially low on any of those electrolytes, that can also be exacerbating this paralytic ileus because we require these electrolytes to make sure muscles work, synapses, all that stuff. So imaging. I don't use a lot of plain abdominal films, but I will occasionally, and you will see gas-filled loops. Just emergency medicine, I'm more CT scan guy, CT scan because I want to rule out a small bowel obstruction, which is more concerning than just an ileus. But if you want to get those types of things, you look at them. Right there, you see those gas-filled loops. Gives you the idea. I will order x-rays on somebody if I think that there's some constipation going on. And it's usually in kiddos. Why? Because they don't like to poop at school. It's a thing. It's a thing. So I will just get that just to reassure the parent. I'm like, yep, they are FOS. You figure that out young. So usually supportive in nature. Pain management, making sure we're giving them plenty of fluids. Last thing is they're drying out and that stool's hardening. We don't want that to happen, so giving them fluids. We don't want them to add to it, and then we don't want to add to it with opioids as well. So potential, if it's significant enough, that we put an NG tube in to decompress that abdomen and help things out. I don't know where he gets these pictures. I don't even know what obstruction point is. Anybody have an idea where obstruction point is? I don't know.
Canada?
Don't waste time looking it up tonight. Study for fun. Anyway, small bowel obstruction. This is more emergency medicine, mechanical obstruction. I told you these are people that have usually had intra-abdominal post-operative adhesions. They develop hernias. Hernia surgeries, cholecystectomies, appendectomies, colectomies, anything that go in instrumentation puts these people at risk. But we also want to be concerned that maybe this is a cancer with a neoplasm, maybe there's some type of stricture, foreign body. Yes, foreign bodies do make it inside of people's bodies. Usually they put them there. And then volvulus, okay, that's where it kind of rolls on. Self-intussusception, that's telescoping. And then gallstones, gallstone ileus. That's crazy. How do gallstones get from the gallbladder into the small intestine? That means it has to go through the cystic duct and then into the common bile duct, past the sphincter of Oddi, past the ampulla of Otter, and then make it into the, I guess it's better, I'd rather have that than have an actual like gallstone stuck in the common bile duct, which is called cholecystectomy. I don't know if we'll get into that. Okay, here's your potential. This is, you're going to pick one of each of these, so it's going to either be functional and then chronic, and then partial, and then closed loop. So they're going to pick one from each of these categories. So 8 options, they're only going to come out with 4 that's going to explain what's going on. Open versus closed loop, meaning it's at a single point if it's open, it's obstructing at 2 locations. You can get that x-ray to get an idea of what's going on, but for a general surgery team, they really want that CT scan. They need to figure out exactly where that is and how big it is. You're not going to get that answer from an x-ray, open or closed, which is going to determine whether or not that person comes in and we just watch them, or they need to go in and surgerize that. So, colicky pain, because we're still having that peristalsis, is trying to push that stool or push that fecal matter through that obstruction, and it can progress to constant pain, nausea, usually vomiting. Obstipation is when, that's why I like to ask people, hey, if you have small bowel obstruction, have you been passing any gas? Have you had any small stool? People are like, nope, I have not been passing any gas. I'm like, man, it's probably small bowel obstruction. It's a much better idea. So obstipation means nothing's coming out. Nothing's coming out. So physical exam, when you see distended abdomen, I like to ask people, is this how it normally is? Not trying to cover anybody because they are a little bit more body habitous. But I just want to say, some people come in and wife and be like, it's never been like that. It's tight and distended, gives you an idea. Timpani and percussion, tenderness, that sweet word again. And so that's just grumbling. So initially we hear grumbling, and then hypoactive later. And then signs of dehydration. Here's your lab test. Here's your last test, lab test. What is the lactate going to tell you? I know everybody's familiar with all this other stuff. You type in cross-match in case that they're bleeding and they need surgery. Type in cross-match guarantees that you're going to give that person a transfusion. It's going to make sure that blood product is not going to cause them an allergic reaction. But lactate is an idea if there's any type of ischemic action going on. Some ischemia, there is not good oxygen delivery to somewhere in the body. Lactate is going to go up. Lactate is very useful in sepsis, very useful in mesenteric ischemia, a clot that's occurring somewhere in the abdomen, not perfusing well enough. And then it's great in people with alcoholics that are on significant benders. So you have that much alcohol that's flowing through your blood system, there's not even enough oxygen. So that's impressive. So initial study with these small bowel obstructions, they do say that in the emergency department. I don't recommend that, but no, this is your initial study. Primary care, because you're not going to get a CT from your TMC, so let's go ahead and just send over an x-ray. That's totally okay. We're going to look for upright and supine. Dilated loops of bowel with air fluid levels is what that radiologist will read that as. I recommend in phase 2, I would put a lot of time and effort into MRIs and CTs, but I would get good at looking at x-rays, because you should have that capability. It's good to look at that and get smart on that, especially with bones. But again, if you have these small dilated loops of bowel, I might say, hey, I'm going to send you to the ER to get a CT scan, because I get it done a heck of a lot quicker. How long does a CT scan take? About 5 minutes. How long does an MRI take? About an hour. Just to give you an idea, some people don't understand that. You can have a head CT done in 5 minutes. That's how quickly CTs are. So there's your small dilated loops of bowel. Again, another x-ray there, which prompts the CT scan, which is going to show us small bowel obstruction, pretty significant. That'll give us usually your transition points. How many small bowel obstructions are we dealing with? How big is that? Is it complete obstruction? Is it partial? How does it fit in those 8 different categories? So fluid resuscitate these people. We're usually going to put an NG tube in. I don't necessarily think you'll put this in at your medical treatment facility, your TMC, but you get this figured out. It's very simple. You're going to call up to an emergency department and say, I'm pretty sure I have small bowel obstruction. Here's what's going on. They're having obstipation. And you talk to the ER doc, and he's probably going to say, cool. You put him in an ambulance and send him up. Because anytime it's from military treatment facility to another one, they should go by ambulance. It's not going to be like, hey, drive yourself there. Don't do that. So early surgical consultation. General surgery will come down and say, not a surgical candidate. They get admitted to internal medicine. Why? Because this can get complicated. We get dilatation. We get compromised. We get ischemia. We get ischemia in there. Lactate's going up. And now we're going to deal with necrosis. Not getting good blood flow. Now it's going to start dying. We have bowel that dies. People die. So we can have this gallstone ileus, which I talked about. And gallstone makes it. all the way down into the small intestine. That's crazy. And all the way from the gallbladder. So more common in older folks, and then diagnosis with CT if you're really concerned about that. Again, not likely you're going to be treating a lot of older folks, but remember, when you're in phase 2, you'll be doing internal medicine, you'll be seeing a lot of older folks. Emergency department, 6 weeks of that, so just be aware of these types of things. And then we have intussusception, so that's where it telescopes. I have a slide for that. This causes bowel obstruction as well. This, if you see on your pants, current jelly stool, you have to think of intussusception, and we've seen these in kids, pediatric patients. Current jelly stool, and that's how that happens there. See how it telescopes on itself. Telescopes on itself. Questions about motility disorders? There's no stupid questions, there's just stupid people. I say that because the two meth heads that got a hold of flare guns and decided to have a duel, they both took 2 steps away from each other, turned around and gave each other simultaneous subdural hematomas in their brains. It's quality. That's quality. And every time they're shot, I was just sitting in my house minding my own business. Sure you were. Sure you were. So don't be ashamed to ask questions. If you are ashamed, you can come see me right after class. It's no problem. I was an infantry guy before I came to PA school, so I didn't even know how to get an IV. And look at me now, I'm just barely making it. All right, neoplasms. We talk about our protein-losing enteropathies. What do we think about with that? We're talking about things that are cancers. We're talking about a carcinoid syndrome. We have graft versus host diseases, people that have had transplants, peptic ulcer disease, and inflammatory or irritable bowel disease. We talk about mesenteric ischemia, another reason to get a lactate. So, small intestinal neoplasms, very rare, which is why we do the colonoscopy. We just look at the large bowel, the colon. Okay, small bowel usually causes intussusception and obstruction. So, most common in the duodenum, proximal jejunum, adenocarcinoma. We talked about that, but we can also have lymphomas. Be aware if your patient is immunosuppressed or immunocompromised, whether that's Crohn's disease, because what do we treat Crohn's disease with? Medications that open the door for infection, immunosuppressive therapies, and then AIDS. You're not going to see a lot of AIDS population or HIV population in the military. So if you have sarcomas, carcinomas, just be aware several different types of neoplasms. And then we talk about our protein losing. This results, we will see usually a decrease in albumin with these folks. And if you have a decrease in albumin, that really ups your percentages of mortality. So GI disorder. So we need to treat that underlying disorder, and then potentially these people are going to be given albumin replacement. That is usually through a hematologist. You're not going to be doing that in your TNC. So you need to see a hematologist and get that. So when we talk about mesenteric ischemia, these are embolic or thrombotic. So embolic means the clot comes across from somewhere else, or thrombotic, it forms inside the vessel, inside tube, occlusion. So I will tell you, these people, mesenteric ischemia, are going to come in, they're going to have pain out of proportion on exam. That's what you should think. Severe abdominal pain. And you touch their abdomen and they're going to go nuts. So pain out of proportion on exam. So, and we're going to get a lactate on these folks because if that ischemia progresses any further and you don't get some type of vascular gastroenterology person involved, they're going to have necrosis. And bowel dies, patient usually goes with it. So right there, pain out of proportion on exam, that's P-O-P-O-E, pain out of proportion. There's 2 other things I get concerned about with that. That's called necrotizing fasciitis and compartment syndrome. Those are the 3 things that I would say, if there's ever a PANCE question that says pain out of proportion on exam, it's going to be one of those 3 is the answer. Hopefully it's not like A and B, they're like, damn it. That's what they're going to do to you. You're going to be down to 2 and you're going to be flipping a coin, losing your mind. Anyway, labs don't specific, but we talk about elevated lactate. Be a little bit more apt to do that in older folks who are lactates. I had a resident that was like ordering lactates on everybody, and I'm like, Rob, you can't do that. It drives the nurses nuts, because every lactate has to be put on ice and typically carried down to the lab. It's just extra stuff. So CT angiographies would be diagnostic study of choice, especially in your hemodynamic stable patients. We don't send people to radiology if they're not stable. These people need to be admitted. So surgical laparotomy, they're going to open them up, usually have some vascular folks. They can do angioplasty based on what that CT angiography says, and then there's potential that they can give them medications as well. All right, who's familiar with this Meckel's diverticulum? This is a pediatric disease typically. Pediatric disease occurs in 2% of the population, usually males, within 2 feet of the ileocecal valve. What does that mean? It's going to be in the right lower quadrant. Typically painless rectal bleeding. Painless rectal bleeding. This has to do with all this heterotopic mucosa. A lot of times has lymphocytes that are involved. So, and symptoms usually occur before the age of 2. This you can potentially see on your pants. Painful or painless rectal bleeding. Painless rectal bleeding, typically in our kiddos. So most of the time, usually, if it is painful, it gets confused with being a appendicitis. But what is our appendicitis? What is our patient demographic? What ages? Any ideas? 10 to 19. So we don't see appendicitis in friggin' 2-year-olds. So this, if it's right lower quadrant pain, it's a 2-year-old or younger, Meckel's diverticulum. So right there, children under the age of 10. Painless lower GI bleeding. So mom says, I saw some bleeding in a diaper. Okay, if they're over the age of 40, so that needs to be done, check that with endoscopy. Couple different diagnoses with how you do that. You can have them take a capsule, which is just going to take pictures all the way down. The book answer, the more important answer, is called a Meckel scan. So that's called scintigraphy. They're going to take red blood cells, they're going to tag them with nucleotide, nuclear medicine study. It's going to find exactly where that bleeding is occurring from. Make sense? Scintigraphy. So, right there, nuclear medicine study is a Meckel scan. Meckel scan. Goes to surgery. Stabilize the patient if you need to. So, in the meantime, rectal bleeding with any type of lower or upper GI bleed, we want to give them some sort of PPI, right? We need to increase the pH, make it less acidic, so that we can get some form of clot formation. Okay, it's too acidic, clots aren't going to form. That's bad. So almost everybody comes in with a GI bleed. I'm like, it's ordered stat before I even know what's going on. So good on that. How about that? 10 minutes early?